Hi, good afternoon, everyone. Welcome to our Multi-Modality Imaging Conference on Cardiac Masses. Maybe Karla is running a little bit late. She usually does the echo portion first, and then I follow with the advanced imaging. But until she arrives, I'll begin and we can get the echo aspect second. So I'll be discussing the advanced imaging techniques and how we can use them to assess cardiac assess cardiac masses. So, usually when by echocardiography, you'll see something, with ultrasound, and the differential is usually the same. Is this a normal? Is this just an artifact that you're seeing, a normal variant? Is this thrombus? Is this vegetation? Or is this a tumor? And this is usually the... Karla? Yeah. Would you like to go first? I started. We'll continue. Okay. So, or tumor. So the question is, which one of it is this? And so we know echocardiography is, of course, our first-line technique. It's a fantastic technique. But really where it has difficulty is with acoustic windows. If you're not able to image the mass in its entirety, it can be problematic. You're really restricted by the patient's body habitus and the views that you have. And then the second big problem with it, of course, is that its inability to differentiate different tissues, or with its poor with its poor soft tissue characterization. And so that's really where these other techniques can be very helpful. Cardiac MRI and cardiac CT can be very, very helpful when you need more advanced imaging. Now, both these techniques, as you know, have a very large field of view, and CT really is king when it comes to spatial anatomy because of its high spatial resolution. But cardiac MRI is not that bad. We are able to see masses in great detail, and it actually has other advantages that can be of great importance to you. And this includes its ability to actually see the functional imaging of the mass, to be able to do tissue characterization of the mass with some of the techniques I'll be discussing, and then to do perfusion assessment. But regardless to say, all of these techniques, when it comes to just describing the mass by its anatomy, where it extends into, and how vascular it is, both these techniques can do very, very well. So what incremental value do you get from these techniques? I think it can definitely help you identify the mass and contribute to a differential diagnosis. It can really, in detail, describe the relationship of the mass to other cardiac and extracardiac structures. And it can be very helpful for you in planning therapy, be it surgery or chemotherapy, if you need repeat serial following. And then if you are going to follow these patients, they can also be very helpful there, looking for tumor regression. Now, I put this slide in by the 2006 appropriate use criteria. Both these techniques are considered appropriate to use when evaluating masses. So a lot of my time will be spent on cardiac MRI because of the strengths that it has with the functional imaging and the tissue characterization. So here's kind of what we do when we do a cardiac mass protocol with CMR. We generally begin with some functional imaging, and that usually is mostly our SSFP cine images that you guys are very well used to seeing. And then finally, after that, we perform real interrogated imaging of the structure of the mass itself. And we do that in two ways. We do that pre-contrast, and that is with techniques such as T1 and T2, fast spin echo, and T2 star, looking for iron overload. And then after that, we'll administer gadolinium, and we'll do further structural imaging of the mass with dynamic first-pass perfusion, late gadolinium enhancement, and long TI imaging. All of these, I'll describe to you what their strengths and advantages are as we go along with this talk. So first, we begin with functional imaging. You can see here are some of our standard cine imaging. What's beautiful about CMR is, of course, being able to see. We have high temporal resolution. We're able to see the mass in its entirety. You can see the entire chest in its entirety. You can see where the mass is extending to, what it's invading, what it's attached to. And what's even more nicer is you're not really restricted in the imaging planes you want to take. So you can really create very non-conventional imaging planes to really describe and characterize these masses in great detail. After we've done the functional imaging, that's really then when we get into our structural imaging, and this is really where we probe this mass. You know, what is its characteristics? Can we make a diagnosis of what it is based on its inherent physical properties? And again, we do this two ways. We do this pre-contrast with our T1 and T2 images. T1 is a great technique. It can help you. Things that are bright in T1 are usually fat, so it can be very helpful in that. T2-weighted images, things that are bright are edema or fluid. And then, of course, T2 star, which is iron. And then we follow that with contrast-enhanced images. And we can, once we've administered contrast, we can actually watch the first pass perfusion of the mass with contrast to help us determine vascularity. Then we perform our general late gadolinium enhanced images. This tells us whether the mass takes up contrast. This can really help us in our differential. As you'll see, one of the key points that I'll keep on making through this talk is that if a mass takes up contrast, it is a tumor, period. So it tells us about, vascularity, fibrosis, and whether it's a tumor or not. And then finally, what we call long TI imaging, and I'll show you some slides what all of this means, but basically this is our probe for detecting thrombus. So what is this T1 and T2, right? These are this is inherent physical properties of any element or structures in the body. In different T1 or T2 MRI-weighted environments, different tissues behave differently. The key point is, fat in T1 images tend to have a very rapid recovery, therefore they appear bright, whereas in T2-weighted images, they decay very rapidly, equally as well, and so they appear dark. Whereas another substance, such as liquid, here represented with the green line, has a long T1 recovery, so in T1 images they'll appear dark, and has a very long T2 decay as well, and therefore will appear bright in T2 imaging. So these are two probes that we can use to help us figure out whether something is fat or liquid. Here's an example of a mass at the apex of the heart. We are injecting gadolinium, and we're taking pictures serially through time, watching contrast as it perfuses the right side of the heart, the left side, and finally this mass. So it gives you an idea of, again, vascularity. This was an image of a mass with minimal vascularity. Contrasted this patient who has a large mass here in the anterior mediastinum, and I hope you'd agree that the amount of contrast in there is as much as you would see in the myocardium, in the LV cavity. And finally, the other probe that we do at post-contrast for structural imaging is to determine whether something is, we perform late gadolinium enhancement images. And the concept basically here is that tumors will take up tumors will take up contrast. And this is going to be one of those serial points that I'm going to keep on making throughout this talk. What we do here is we use a particular sequence where we null the myocardium dark. So anything that then takes up contrast will be evidence of either some fibrosis, some scarring, or in the case of tumors, a mass. And so this is one other sequence that can be very helpful for us, and I'll show you more examples of that. And finally, the other structural probe that we do in patients with masses is where we can actually interrogate for thrombus. So like I showed you in the prior example where we actually null the myocardium to be dark, here we use a probe where we actually null thrombus to be dark. So this is a particular situation where we image at a time, what we call a very long TI. This would be a time point where something that has no contrast in it will appear jet black. And so generally, that's one of the definitions of thrombus, that these are avascular structures that do not manifest any gadolinium uptake. So on these images, if you see something dark, more than likely it is thrombus. Myocardium, vasculature, all those other structures in these sequences will appear bright. So this kind of makes up, the different ways we probe tissue characteristics with CMR. So what is our thought process, when we are, as CMR physicians, when we have a case that you refer to us, is this a mass? And tell us a little bit more about it. First question we have to ask is this a true mass or a pseudo mass? So here's an example of a case with ultrasound. And I hope the movies are a little bit jerky here. But you'll see a structure here in the posterior right atrium. So this patient was 74. He really came in with a stroke. There was, of course, this mass was noted in the right atrium. And, there was a concern that, this was something significant and therefore was referred to the CMR lab. So, here I show you the representative CMR images. This is normal. This is a normal variant. This is just a very prominent crista terminalis that we're seeing. But I hope you can see that you're able to vary with CMR because of the spatial resolution, because of the ability to have a large field of view. You can really look at this structure and make sure it truly is a benign structure. So first thing is, you got to differentiate tumor from just normal variants in the heart. Here's another example of a case. If you're looking at this heart, I hope you'd see that structure, something concerning in the left atrium. This was a patient with coronary artery disease who was admitted with epigastric pain. Now, this patient was sent to the lab, and you can see here that actually in the left atrium there was nothing there. Now, of course, the echocardiographers in the audience will probably have made this diagnosis without needing a cardiac MRI, but sometimes we get referrals from outside institutions, and we're left to try to kind of tease this apart. So what exactly are we seeing on the ultrasound? Well, actually, if you look at a stack of images that we take through the entire thorax, this was actually a large hiatal hernia, and this was just the hiatal hernia coming in and out of view as you were imaging the posterior left atrium. Now, Dr. Q, I'm sure if he was reading in the lab, he would have said, give that patient some Pepsi and let's re-image him, and you would have noticed a lot of bubbles in that area and you'd have made the diagnosis that way. But, it's just showing you the importance that, you got to differentiate, again, true masses from something that's just a normal variant in the heart. So on that account, Karla will hit upon a lot of these. You have to know normal structures in the myocardium before you start calling things pathologic. The second step that we make, once we've identified that a mass is truly a mass, we have to figure out, is this a tumor, or is this what we'll term as a pseudo-tumor? And under the tree of pseudo-tumor, we've got a couple of other things that this mass could be. Could this mass be fat? Is this simply just fluid? Could this be calcium? Or is this thrombus? So these are very important to differentiate before you call something a tumor. So how do we do that with CMR? So here's a structure by echocardiography. The acute echocardiographers, of course, know the diagnosis right away. This is a dumbbell shaped looking structure that's echogenic. It seems to spare the fossa ovalis. And this is exactly what you see with CMR as well. But what CMR allows you to do is, of course, really probe what you're looking at. And so using our T1 spin and T2 spin echoes, you can see here on T1 spin echoes that this structure is bright, and on T2 with fat saturation that this structure is completely dark. And for us, this is, and for everyone else, this is pathonomic for fat. So you can, without having to even know what this was, if you didn't recognize it by its anatomy, you can make a diagnosis based on its tissue characterization. Similarly, look at this case. This was a case where there was some compression of the right side. It was unsure what was going on. This patient was sent to us, and you're seeing this very large cystic structure next to the heart. What is it? And simply, again, here I show you a series of T1, T2 images and late gadolinium enhancement. what you're noticing is the opposite from what we saw with fat. You're actually seeing a dark image in T1, a bright image in T2 with no evidence of contrast uptake. For us, this is water, as simple as water. And so that you can very quickly make the diagnosis just based on tissue characterization that, you know, this is something that has a lot of water in it. This is a pericardial cyst. So here's another case. This is a real example. This case was referred to us from Louisiana to Dr. Reardon to operate on a mass. And what was interesting was just a little while earlier, this patient had 2-vessel bypass at this outside facility. And on a post-op echo, they seemed to have diagnosed a new left atrial mass. So here's this mass. You can see it's located in the left AV groove. It seems very large. What is it, you know? Here are again, we're using tissue characteristics here, both pre and post contrast. You have your T1, T2, first pass perfusion, and LGE images. If you'll notice on the T1 and T2, this is a little bit different. This is completely dark in both sequences. So, what is dark in those sequences? Then, if you look at the first pass perfusion, it's also completely dark there. So that means there's no vascularity to this structure. And then finally, on the LGE, it actually gives this very pathognomonic, classic look to it, where the center is dark and you have this rim of fibrosis or delayed hyperenhancement around this mass. Now, you know, probably you're absolutely right. You didn't need to get to the stage of a CMR to make this diagnosis, but if they do make it to the CMR lab, a structure that stays dark in all your sequences is calcium. And, you know, we image protons, we don't image calcium. So hence, you know, calcium will stay dark in all of our sequences. And you get in cases with this very aggressive mitoannular caseation, you often see this rim of fibrosis, the body trying to wall off this calcium that is present. So, you know, we did this for the heck of it. I sent the patient off to Dr. Mamarian. You know, we got a non-contrast CT. You know, and you see this just. I'm not joking. Yes, yes. You see, you know.
All of these diagnoses would have been diagnosed in 5 seconds with CT.
You see a stone in the heart, you know. So another example of stone in the heart, Danny. And then, of course, if you were to, sure, you know, I'm not going to deny the echocardiographers, you know, if you were to look at the echo, most of us would have made that diagnosis on echocardiography. So, okay, so again, just the importance of differentiating tumors from pseudo-tumors. So how about this? Now, the history is should give you a good idea of what this is going to be. You know, diabetic mitral valve replacement has chronic atrial fibrillation on oral anticoagulation. Okay, has a normal EF, admitted for diastolic heart failure. You are seeing 2 very large masses almost prolapsing through the tricuspid valve in the right atrium. Now, sure, history makes us all very suspicious of thrombus. But again, the beauty of CMR is we can use tissue characteristics to really probe what this is, in case, you know, it's a zebra. And so here's an example, you know, on T1 and T2, you really, you know, you're just seeing, you know, you're not really seeing very good image quality there, you know, on the T1, T2 images. If we look at first pass perfusion, you can see these masses. As you see contrast going through the heart, there's absolutely no contrast uptake of these masses. But more importantly, one of the sequences that we use post-contrast is this long TI imaging, where we set the TI time or the inversion time to almost 600 milliseconds. And what that allows you to do is the only thing that will be jet black in these images is something that is completely avascular, that has not taken up any gadolinium. And that, by definition, is a thrombus. Everything else, you'll notice, will have a whitish look in the images, including the myocardium, because it has contrast and it, you know. So this sequence is done in such a way where only things that have completely devoid of contrast uptake will appear jet black the definition of a thrombus. And you can see these things are completely jet black. So with confidence, you can say that this is thrombus. So what is the data? Okay, and here's another example. This was a mass that was seen on this heart here in the anteroseptal wall. You can see it's pedunculated. It's just sitting there nicely. Is this normal myocardium or is this a mass? You know, you do your long TI imaging. It is very clear what this is. You can see the clear differentiation from the surrounding myocardium. This is thrombus. It's jet black on these images. And to further prove this to you, this patient was anticoagulated. You can see this mass is completely resolved. What is some data behind CMR and thrombus imaging? I think this is some of the strongest. 160 patients who had all imaging techniques and then actually went to the operating room for final determination at 30 days for pathological confirmation. Thrombus was present in 39% of the population here. And what you can see is compared to the other techniques, CMR had the highest sensitivity, and when we said it was thrombus 99% of the time. This was another study that was performed. This was a study that used CMR as the gold standard and looked at and compared it to both non-contrast echo and contrast echo. And you can see here in this patient population where 20% of thrombus was present, you can see the sensitivity of a non-contrast echo for the detection of thrombus was actually very, very low. Now, you can see that with contrast, that improved to 61%. This was still inferior just to cine CMR imaging. I think in our own experiences as echocardiographers that we would agree that, you know, generally contrast is very, very beneficial, and Dr. Zogby has been shown many slides where, you know, contrast really saves the day and can help you make the correct diagnosis. Obviously, if you do see what you believe is thrombus by a non-contrast echo or contrast echo, vast majority of the times you are absolutely correct. Where did echo have problems, you know, compared to CMR? Where it had problems was if you had a very small thrombus, that kind of makes sense. You know, it can be easily confused with trabeculae, or you may not just have the imaging window to have seen it. Or if it was a laminated kind of mural thrombus where it just blended in with the wall. And we have some very nice cases where we found thrombuses actually in the left atrium, which is a much thinner wall where you have this just nice, smooth, laminar clot lining the back of the wall that can be missed by any technique, including TEE. How else can CMR be helpful? Obviously, just like echo, you know, as your ejection fraction falls, the risk of having, the predisposition to a thrombus is higher. And similarly, the greater the number of akinetic or dyskinetic segments. So it can really help you look for the structural defect that you need to have thrombus. This was one study that looked at a bunch of CMR sequences and compared them for their ability to detect thrombus. And again, really the sequence that is our thrombus probe is our long TI imaging, here having an accuracy in this study of 95%. And so this is the third, once you've made sure it's not an artifact, you've ruled out the pseudo-tumors, including thrombus, the last thing left is this is going to be a thrombus if it takes up contrast, and is this benign or malignant? So that's kind of where my talk is going to transition. And this is kind of an example of that, so we have two masses here, one on the right-hand side of the screen. You can see this at the apex. You can see both on first-pass perfusion and late ganglion enhancement that there's no evidence of contrast uptake. This would be consistent with thrombus. Whereas tumors always will take up contrast. They have vascularity. Gadolinium will make its way into the body of the tumor. Notice I'm not saying whether it's benign or malignant. I'm just saying tumor contrast uptake equals tumor. These are some other examples from our own Dr. Kasi, an example of a myxoma and sarcoma, how they look with CMR imaging. Main thing I want to stress is in all the contrast sequences, you have evidence of contrast uptake. These were diagnosed as tumors. And this was one of the studies out there in the literature, apart from Dr. Kassi's, that looked at how to differentiate tumors from thrombus. And basically, if you look at my red boxes, tumors always had, in all sequences that evaluated contrast uptake, whether it be first-pass perfusion, late Galilei enhancement, or your long TI imaging, they all consistently demonstrated contrast uptake. So this brings up back to our stepwise evaluation of cardiac masses. Step 1, make sure it's a true mass or a pseudo-mass. Rule out all the hiatal hernias and the normal variants that we see in the heart. If it's a pseudo-tumor, rule out the fats, the fluids, and the calcium with our simple T1, T2 structural imaging. Rule out thrombus with our long TI imaging. If you will, by that point, likely have contrast uptake, you're now have diagnosed a tumor, and really step 3 is then creating a differential diagnosis for the physician, helping them to help navigate whether the mass is benign or malignant. And here, I think we borrow what echocardiographer and CT physicians do all the time. There's really nothing that there's just based on tissue characterization, I cannot make the diagnosis of benign versus malignant, but there are other qualities about the images that can help us to make that diagnosis. The larger the size, the more irregular the borders, the more invasion and traveling through tissue planes, the presence of pericardial effusions, the presence of metastasis. You have large field of views. Look for spread of cancer or metastasis to other organs that you're able to see, or if you have multiple lesions. And this is really what this one study that looked at, also trying to differentiate benign and malignancy. You can see all the values are really intermediate. It's hard because both tumors, whether benign or malignant, all take up contrast. Okay, so I think we've discussed this. So really, I think it's important that as cardiologists, especially imagers, you should know that that they are primary and secondary tumors. Secondary tumors are 20 to 40% more common than primary cardiac tumors. Secondary tumors include metastasis that is spread directly from the lungs, hematogenously through the blood or through the lymphatics. These are most commonly breast melanomas, hepatocellular, renal, sarcomas, and then the primary tumors, which vast majority are benign, 75%, which includes your myxomas, papillary fibroblastomas, fibromas, and then the rare malignant primary tumors such as, and the most feared is your angiosarcoma. Location of where the abnormality is can be very helpful in creating a differential as well. If things are in the ventricles, they're commonly fibromas or rhabdomyomas. If they involve the valves, they're fibrolastomas or vegetations. If they're in the atria, you should think about myxomas, thrombus, and of course the sarcomas. If they involve the pericardium, think about metastasis or cysts. So these are things that, based on where structures are, helping you to create a differential of what it is. So I think, when it comes to really diagnosing a tumor, it's really a combination of clinical history, signs and symptoms, biochemical tumor markers, and what tissue characterization and all the tumor cardiac imaging that you can do. So remember these tests. TEE is great for small, highly mobile masses. CT can be excellent for calcified lesions, and for patients who may have a lot of problems with claustrophobia or have contraindications to CMR. Consider CT in end-stage renal disease patients. Everybody else, I think, should get a CMR. All right.
Quick question. Last year, remember, last year we had a case. There was a lot of controversy between CMR and CT. Patient went to surgery. Refresh my memory on that case, because that case was fascinating. It was a clot, right? It was a clot, but CMR was struggling with it, right? I mean, I'm not bringing this up to shame you. It's just basically what were the explanations for that problem? That
I
issue?
don't remember the exact case, but what I will say is you'll find where CMR will struggle when differentiating thrombus. I think if the mass is very, very small or very highly rapidly mobile, we're going to have a hard time. Our images are made over several cardiac cycles. We're going to have a little bit difficulty.
Because I think with the CT, it was the. You remember the case more, Carlos? It was really a big lesson for everybody in that case.
I think the reason it confused MRI is that it took contrast and it was labeled as a non-clot. But then by location in the aneurysm in the root, there was an aneurysm and it was like sitting there as it's a mold. So by TE, it was diagnosed as a clot. But then CT also, yeah. But then I think the reasoning was it was fresh or something, so it was. So
And by CT took up contrast, or it was?
No, but I remember by MRI it took contrast.
We discussed it back and forth. Yeah.
Okay, all right. Yeah, I'll definitely look into that case. We'll try to investigate that a little further.
I mean, you have to analyze the sensitivity and specificity for each one of these. They're not, if you look at MRI, the sensitivity was 66% or 60, whatever, 70%. Echo without contrast is in the 30s. And echo with contrast is about in the 60s. And each one is different, right? Don't jump, just listen. Just listen. All right? So for MR, if you have a small lesion that is very mobile, it will have problems. So it depends of what your cohort that you're studying. For echo, it is a problem in two things. One, the tomogram by which you're looking at, because it's tomographic, and you may miss it completely, particularly in the apex. We've had an older study that we never published. It was as an abstract when Mari was here. And in 3D, you miss less because you're looking at the whole heart. But the problem comes is in layered ones that look like fibrosis. If you have a wall motion abnormality, and I think that's what we've looked at before, if you have a wall motion abnormality, when it looks like a scar on it, you may miss a thrombus because it's not too thick, and it's layered, and it looks like a scar, and you never call it as a thrombus. And these are the two major issues. Now you can comment.
The study that Faisal was referencing, that was cine CMR, had a sensitivity of identifying thrombus at about 60-some%. That was not delayed enhancement. That was not contrast CMR for tissue characterization. So, in fact, that was what was used as the reference standard for that study. And the point of that study, because I know because I was involved in that, was that any anatomic-based technique, no matter how high resolution or how good it is not going to be able to pick up these layered thrombus. You need to be able to probe for differences in tissue characteristics.
Right.
And that's how you're able to identify these layered thrombus.
But we agree that
No, I agree.
if,
I agree
if
with
it
you.
is small,
If it's, right, so
and
small,
certainly mobile, this is not the test.
Right. So if you think about it, the spatial resolution of a CMR is about 2 millimeters. So you want to have 2 or 3 pixels across the structure. So if you have something that's less than 5 millimeters, or if it's very highly mobile, it's going to be hard to be able to identify or to really characterize this thing by CMR. I absolutely agree with you on that.
All right.
Okay, we're going to switch gears. This is for all of you that need your echo CMEs. So let's go. So echo compared to CT and MRI, there are advantages. I mean, after Faisal's talk, you'd think there weren't any, but there are, as Dr. Zagby was alluding to. And the first one is it gives you a dynamic real-time evaluation. What does that mean? Well, you see what the mass is doing when the heart is beating, throughout diastole and systole. So it's real time. It's not images that are compiled retrospectively. So it's real-time imaging. The extent of the mass within the heart can be determined. The hemodynamic consequences of the mass can be determined. And there are predisposing conditions that can be identified, such as an apical LV aneurysm or rheumatic valvular heart disease that can predispose to these masses. So those are all very important. There are disadvantages, suboptimal image quality in 10 to 15%. We realize that. So this results in either more invasive measures such as TEE or just missing that mass altogether, which we have some examples of that. It has a very narrow field of view. You only see the heart. So the extra cardiac manifestations of the mass are not delineated. So if the mass is coming from the lungs and metastasizing to the heart or vice versa, you're not going to see that. That part in the lungs. You can mistake ultrasound artifact for a mass. So I think we all agree there are probably more artifacts on echo than there are in MRI, and we'll go through some of that. And of course, it can't provide data on the tissue characteristics of the mass, which Dr. Nabi spent a long time discussing, like whether or not it's calcified, which CT is the best, or fat or fibrous or thrombus, MRI is the best. So I think we solidified that piece. Now, in echo, you really have to know the normal structures that can cause artifacts. So, so that you don't call them masses, so the patient doesn't end up with an MRI. So those things include the raphe between the left upper pulmonary vein and the left atrial appendage and the left atrium, the atrial suture line after a cardiac transplant in the left and right atrium, artifacts secondary to calcified or prosthetic valves, both aortic and mitral, and secondary to mitral annular calcification. And the right atrium, frequently in people will have prominent crista terminalis, and that has been shown to be the #1 reason why people get referred for TEE is a prominent crista terminalis, which Dr. Nabi showed us a good example of that. You can have Chiari networks, eustachian valves, lipomatous interatrial septal hypertrophy, pacemaker wires. They can all cause artifacts and make you think that there's a mass there. In the LV, you have aberrant papillary muscles and tendons and chordae. If they're not in the usual positions, people may think that they're abnormal masses, but they're just variants. The same in the RV, specifically in people with pulmonary hypertension. The moderator band gets big, the papillary muscles get big, and sometimes those things are seen as masses when they're just normal variants for that patient. So basically, what questions should you ask when trying to determine, is this an artifact, is this an abnormal cardiac mass or a normal variant? Well, you need to look and see if you see that mass in the exact same location on multiple different views. If you do, well, then it's not an artifact, it's real. Then it becomes either a normal variant or an abnormal cardiac mass. If the mass looks like it's posterior, well, TE is your friend, because TE gives you excellent visualization of those posterior masses. Those things that are located in the left atrium or in the mitral valve or the aorta. You should use echo contrast if the image is suboptimal, and we'll show some good examples of that, especially in that LV apex. And you really need to integrate your echo in your clinical data when you're trying to discover or determine whether or not it's a pathological mass. So this is an example. You see a highly mobile mass there on that right atrial free wall. You also see the interatrial septum is very mobile there. And this is just a classic picture of a eustachian valve and atrial septal aneurysm. These are all normal variants, even though that atrial septal aneurysm frequently is associated with PFOs. So this is a 62-year-old man with sepsis, and again, you're seeing that there's something in the right atrium on this TE view. It's very mobile, and you can see the interatrial septum looks like a dumbbell. And then on the view at 136, you can see there's a lot of bright infiltration around that posterior right atrial wall. These are just classic appearances of lipomatous hypertrophy of the interatrial septum and RA free wall, and that's just the catheter that was there, that was placed in this hospitalized patient. So a normal variant for hospitalized patients. So once you've established that it's not a normal variant, it's not an artifact, then the question always becomes, well, is it a thrombus, a tumor, or a vegetation? We use 4 main things on echocardiography to decide. And the first is the location. So the thrombus is always located in a large left atrial appendage, or it's somebody with AFib, or LV apex if they have apical aneurysm, or it's going to be in the IVC, RA, or RV if it's in transit. Tumor can be anywhere, any cardiac structure, any place in the heart. Of course, a vegetation usually is on the valves. The appearance, thrombuses are very pedunculated or spherical if they're in transit. If they're mural thrombi, again, they're harder to detect, which we know, and they're usually located in apical aneurysms on the LV side. Tumor is going to vary. A vegetation is very regular, highly mobile, located on the low flow side of valves. The third thing we look at is associated findings. So for a thrombus, we're looking for LV dysfunction with wall motion abnormalities. If it's in the left atrium, we're looking for mitral stenosis and atrial fibrillation, which really increase the odds of that being a thrombus. If it's in transit on the RV side, we're looking for RV dysfunction to indicate that it's already a pulmonary embolus. Tumor, we're looking for invasion, obstruction, and if it's in the pericardium, collapse of the chambers. And a vegetation, we're just looking for regurgitation and stenosis of those valves. I think probably the most important thing is the clinical history, because the clinical history can really help you guide you when trying to determine if it's a thrombus, a tumor, or a vegetation. So this is an example of a 48-year-old man with syncope, and you can see that the mass there in that four-chamber view is huge. It's very homogeneous. It's almost filling up the whole left atrium. You see that it gives you an appearance in that upper left-hand corner that there's a stalk attached to that posterior left atrial wall. On the zoomed up four-chamber view, you really can't tell, but still very homogeneous. And on that apical one, again, I can't really tell where it's attached, but it's a large homogeneous mass. This is a very classic appearance just because of its location and its homogeneous appearance of a myxoma, which is the most common primary cardiac tumor in adults. This is a 68-year-old woman with dyspnea. And here, the left-hand picture is, our video is of a circular, it's the intravenous IVC. So you're seeing a very circular mass there in the IVC. And then a few days later, there's a subsequent image there in the same patient. And you can now see that that very circular mass in the IVC is now in the right atrium, and it's trying to find its way across the tricuspid valve. So this is a very classic example of a thrombus in transit. Now, this was a 21-year-old patient who came in with dyspnea, fever, and chills. And you can see on her peristernal long axis, she has a very irregular mass in the right ventricle. It's very mobile. When we zoom up on it, again, you can see it's attached to probably the membranous interventricular septum. And when you look at the short axis, you can see how big it is. It's extending all the way to the pulmonic valve. But the money shot is actually that apical lung, because you can see that there's a little membranous ventricular septal defect. And on the low side of that membranous ventricular septal defect is this mass. And with this clinical picture, this tells you that this is endocarditis. And this lady actually was using IV drugs, and this turned out to be staph and was also present in her lungs. It had embolized to her lungs. So this is a 19-year-old with lupus and altered mental status. So this was a cardiac source of embolus workup. So this is a TEE, and this is zoomed up to show you the mitral valve. And what you're seeing is there's diffuse thickening of those leaflets from the very tip of the leaflets all the way down to the base of the leaflets. So she was subsequently determined to have lupus cerebritis. So that's a classic picture of Liebman-Sachs endocarditis or valvulitis. It involves the whole valve, the whole valvular tissue becomes inflamed. So this is a 73-year-old man with ischemic cardiomyopathy, and the whole question is there a role for echo contrast in this patient? When you look at this, it really looks like, you can't see the endocardium of the apex very well, but it really looks like the epicardium is going outward, and so it's probably going to be akinetic. And when you look at that 3D view, it looks like there may be some sort of a mobile pedunculated mass up there in the LV apex. But this person absolutely does need echo contrast. And you can see when it was given, the apex is actually hypokinetic and there's nothing, absolutely nothing there. Here's another gentleman with coronary artery disease. And the question again is, should we give echo contrast? I know the sonographers go through this a lot. And you're looking at this one and you're saying, well, the epicardium looks like it's moving normally. I can't really see the endocardium, but on both of and I can't really see the anterior wall or the mid-lateral wall. So there's more than two walls that I can't see, so I probably should give echo contrast. But you're thinking the yield is probably going to be low for finding something up there. But sure enough, this patient has a very focal apical defect, and in there there's a nice pedunculated thrombus. Now, Dr. Nabi covered this about tumors. Usually they're metastatic. 95% of all cardiac tumors are metastatic, usually from structures within the chest. They involve the pericardium 75% of the time. And of the primary cardiac tumors, usually they're benign, 75% of the time. Most commonly, you're going to see a myxoma. And the most common malignant primary cardiac tumors also involve the pericardium, just like the metastatic ones, and we use that in trying to determine is this malignant or benign, and angiosarcoma is the most common one. So here's an example of a 44-year-old man who presented with dyspnea, and basically what you see here is the RV is enlarged. It's like twice the size of the LV. You can see it's filled with this mass, and when you look at the RV free wall, you can see it's moving normally, but from the mid RV all the way up to the apex, it's no longer moving. So that's telling you that that mass is likely invading that RV myocardium and increasing your suspicion that this is malignant. And then you look on the short axis, and again, you see there's a small pericardial effusion, which also, as Dr. Nabi talked about too, is increasing your suspicion that this is malignant. And then when you look at the perfusion, you heard about perfusion on MRI. Well, this is our echo perfusion. And again, you can see that there's speckles within that mass, which is telling you that that mass is perfusing, which also goes along with, malignant. And then I think the subcostal view is very, very nice because it's showing you that the RV free wall is moving normally, but as soon as you hit the mass, it's no longer thickening, and that mass is filling up the whole thing and invading onto the tricuspid leaflet like malignant masses do. They just destroy. And you can see the pericardial effusion. So we were highly suspicious that this was a malignant cardiac mass, and this turned out on path to be an angiosarcoma. This is a 36-year-old woman who also had shortness of breath, and this is a TEE, and you can see on the upper left-hand corner that there's a big mass there attached to the intratracheal septum. As they turn, you can see it's involving the pulmonary vein. So the very bottom one shows you the right lower and right upper pulmonary veins, and you can see that they're completely filled with this tumor. When you see this, it suggests hematogenous spread, and it suggests that it's come from the lungs. And in this, because it starts in the pulmonary veins first, and then it spreads on to fill the whole left atrium. And this is exactly what this was. She had a known pulmonary mass when she was referred, and they knew it was a sarcoma. And they just wanted to determine how much involvement of the heart there had been, hence the need for the TEE. So I put this up here just to remind us that myxomas, they don't frequently, not frequently, but you can see atypical presentations. So yeah, most of the time, 75% of the time, they are in the left atrium. But 15% of the time, you'll see them in the right atrium, is in the upper left-hand panel. 5% of the time, you'll see them in the LV, is in the upper right-hand panel. And you can see they have when they're in this one in the LV had a very irregular appearance. We didn't think that was going to be a myxoma. But there's the surgical specimen down below, and that's exactly what the path showed us. And it can be multiple if you have familial syndromes like NAME or LAM. So this is a young lady with Behçet's, which is an autoimmune inflammatory condition. And you can see that she has a very mobile mass attached to her chordae in her right ventricle. And the question was, what is that? And you can see there are very beautiful contrast-enhanced images. And you can see that that mass is very mobile and very adherent to those right ventricular chordae. So it was decided that this mass needed to be removed. She underwent surgical recision. It got sent off her path. It came back as inflammatory infiltrate and actually recurred on her artificial chordae in her right ventricle a year later. So this is just one of those very, very, very autoimmune diseases that's associated with significant amounts of inflammation. So this is a 50-year-old woman with hypertension, and she just got referred to the echo lab to, I guess, evaluate for LVH. And you can see that this is you can see on her TE and transthoracic images that there was a mass that was identified. You can even see it on the TEE, a very mobile mass in the apex of the LV, which is unusual because the apex is moving normally, so we really didn't think that was a thrombus. So if it's not a thrombus, the question was, well, what is it? And does it have an embolic potential? Because that would be the only reason you'd take it out in a patient like this, because the chamber sizes are all normal and the chamber function is all normal. So it was decided that, because it's so mobile, this probably has significant embolic potential. So she was sent to surgery to have this mass removed. And this is actually her surgical video, compliments of Dr. Reardon. You can see here he's cutting into the left ventricle through the epicardial fat. And eventually, once he gets inside, you will see that he's going hunting towards the apex. He's cutting through a lot of trabeculae to try and find that mass. And you can see it's that little yellow mucoid thing that's behind all these trabeculae way up there in the apex. I think what was really evident from this video is that mass was very strongly adherent to those trabeculae, so it probably wasn't going anywhere. Because it takes them a long time to free it up and dig it out. So this was pre-CMR days. Can you believe it? That's how old this video is. Yeah, isn't that interesting? The surgeons always have a front row seat to actually see these things. And they look so different than they do on the images. So that got sent to pathology, and basically that came back as a papillary fibroelastoma. And that's such an unusual location. They're always attached to chordae and the high flow side of valves. They're usually never attached to trabeculae. So that's exactly what that was. So we're going to skip all of this. We'll just show you a few more cases in the last 5 minutes. So this is a 59-year-old patient, Dr. Hughes, who has heart failure, AFib, and he has a previous AVR in there, and I think that's a Star Edwards, if I'm not, yeah, I can't remember, but it's a really old prosthesis, and I think that's what it might be. And you can see he's got this very echogenic mass located there at the base of the interventricular septum. Yeah, intramyocardial. It's going all the way across the ventricular septum. It's big, and it's really big. And so we tried to figure out what it was. Here's contrast. It looks like it's enhancing with our echo contrast because it's just as bright as the inside of the ventricle as, you know, the mass is just as bright as that. So we thought it was enhancing with echo contrast, which suggests that it's perfusing, right? It's taking up contrast. So this patient went on to MRI, and this is courtesy of Dr. Nabi. And the T1 images showed that the mass is mildly hyperintense to the myocardium. The delayed enhanced images show uptake of contrast around that mass. You look at me and think, what is it? And here's the T1 weighted city. And again, you can see that mass is a big mass in the interventricular, basal muscular interventricular septum. So we still don't know what it was and what to do with it. So the patient went on for cardiac CT, and you can see that that septal mass appears similar to blood, which still, you know, the inside of the heart and the mass, the cavity look the same, suggesting that that mass is probably perfusing. And this is the contrast-enhanced cardiac CT images. There you can see the myocardial prosthesis, and here you see the mass right after it, and you can see it's got a lot of calcium in it, but it's not all calcified because there also is non-calcified elements to it. And this is the non-contrast CT images, and you can see that it's very pink and it's very white, which is saying that it's very, very calcified. And so basically, after all of this, we came to the conclusion that it's probably most likely a fibroma, and we came to the conclusion that it was so large and was taking up so much of the basal interventricular septum that there was no way that they could safely remove it surgically and patch the interventricular septum. Yeah, he's doing okay, right? So we left it. Dr. Q follows him, but yeah. And here's one more fun one. This is a patient of mine. She was 21 years old, and she was having abdominal pain for years and palpitations. And had multiple imaging, and no one could figure it out. Well, this was a chest X-ray that shows this really thin line where next to the arrows, there's a little thin line there. That was our first hint that there may be something seriously going on. So this led to an echo. And you see the very thin line coming across the mid-interventricular septum on both of this 4-chamber view and this 3-chamber view. So we're like, oh my God, what is that? Yes. So this led to CT, or this is her CT scan. And again, you can see, there it is. And it's there on both of the images. And it looks like a wire. Everybody was saying, this has to be a wire. This looks like a wire lodged in her interventricular septum. So fortunately, she'd been having abdominal pain for years. So we're like, okay, let's go back and see if she had some CT scans of her abdomen. And this lady had been in a motor vehicle accident as a teenager, and they had put in a filter at that time, one of the retrievable filters, and just left it in there. And then, the doctors who took care of her at the time of her trauma weren't her long-term follow-up doctors, so it got forgotten. And you can see on this abdominal CT scan from March of 2012, she's got all the struts, and then on June, one of the struts is missing on the very bottom. So then we said, okay, we know what this is. So this is a IVC strut fracture. One of the struts has migrated and pierced itself into the interventricular septum. And this is what's causing her, probably her abdominal pain and her palpitations. The only question is, well, how do we get it out? So this is one of the barred retrievable filters. So actually, the company actually helped because, this filter has been fractured a lot, and there's a lot of lawsuits. So they actually sent their expert to come down and help us remove it. So you can see this is what it looked like on fluoro. They removed the fractured filter. The reason we had to move the filter wasn't just because she had abdominal pain, but one of the legs is missing, so then all the other legs become loose. And they had also a high likelihood of migrating over the next few months. So we moved it the usual way that they recommend. And then when after that fractured strut that was lodged in the heart using a bronchoscopy, one of those bronchoscopy forceps, and snared it. Yeah, and what's interesting is after they did it with fluoral. Yeah, they could see it with fluoral because it was metallic. And what's interesting is once that was out, all of her chest pain, abdominal pain, palpitations, everything went away. And, I saw her in follow-up for, a few months afterwards, but then she didn't have any other cardiac complaints. So we just sent her on her way for all her other complaints that she had. So I frequently get asked this question, what is the role for echo after stroke? And basically what we're looking for is an intracardiac mass that may have partially embolized. We're also looking for something that may predispose to the development of an intracardiac thrombi. And we're also looking for a cardiac abnormality that may serve as a potential source for systemic embolization. But that all said, it's only positive in 10 to 15% of cases. So most of the time, we're doing this and we find nothing. But I'm going to show you some cases where we actually found something. So this is a left atrial appendage. You can see that this is filled with thrombus, and this is in a patient who obviously has AFib. And that was treated appropriately. This was also showing you that on that TE, we found extensive atherosclerotic plaques, which were also ulcerated, which also might have been responsible for that stroke in the ascending aorta. This is just showing what we do all the time, looking for a PFO, and we found one. This is somebody who actually had a stroke and a pulmonary embolus at the same time. And you can see there's actually a thrombus on this 2D and 3D imaging that's lodged in the PFO, half of it on the left atrial side, half of it on the right atrial side. Now, I also get asked by the fellows, this is one of my last slides, when is a TEE appropriate? This is based on the 2007 appropriateness criteria. And you can see it's appropriate for anybody who's had an abrupt occlusion of any major peripheral or visceral artery in patients of any age. If they're less than 45 and had a stroke, it's appropriate. If they're greater than 45 and no evidence of cerebral vascular disease, it's appropriate. And anyone with known heart disease is appropriate. So that's almost everybody. I can't think, there's very few people other than they found a definite atherosclerotic plaque in the brain that you wouldn't do it. But everybody else, it's pretty much appropriate. This is a case of a 67-year-old woman with lupus and a stroke, and you can see this is a TEE. And on her mitral valve, she has this very pedunculated mass, homogeneous mass on the low flow side of her mitral valve. On her intraatrial septum, she has a larger homogeneous pedunculated mass attached to her intraatrial septum in the left atrium. And then on her ascending aorta, you can see that there's a lot of mobile there's a lot of mobile plaque or atheremboli there in her ascending aorta. So she had multiple reasons for her stroke. She ultimately underwent and had those masses removed, which in retrospect wasn't the best because this lady they all ended up being thrombi, and she ended up having antiphospholipid antibody syndrome. So that's why she had all of those thrombi located there in unusual places. And she had a very poor outcome, very poor outcome. And this is a patient of mine. Again, she came in with facial droop and left arm weakness. And you can see that there's a very mobile pedunculated mass that's trying to get across the mitral valve. And that's just classic for a thrombus because she's got the protoplasm for a thrombus. She's got AFib, big atrium. And so she went to surgery and they actually removed it because she was having, multiple strokes. Yes, and they removed it, and we knew it was a thrombus, but they removed it just because we didn't want her to have multiple continuous strokes. And she actually did very, very well. I mean, she subsequently went on to get an LVAD, but did very, very well.
Bradycardia is not good in this situation.
And that's it. Thank you very much.
See you next year.